Thank you again for this opportunity, Christina, and thank you thank you all for being here. So my presentation concerns the history of rheumatic fever. Can you hear me clear? Okay. And before going into the topic, anyway, let me summarize the current knowledge about the disease. It is an inflammatory disease affecting joints, heart, and other organs, typically occurring in a small percentage of children with a peak between 5 and 15 years, following group A streptococcal infection, that is either sore throat or scarlet fever, with the latency of 2-3 weeks, which is quite important because it reflects the immunopathological mechanism underlying the disease. The disease, in fact, is triggered by molecular mimicry, that is an immunopathological mechanism classified as type 2 according to the Coombs classification. And the acute rheumatic fever eventually progresses to a chronic valvulopathy, that is rheumatic heart disease. As a disease, anyway, however, rheumatic fever is a history in developed country. Still a major problem in the 19th century, starting from the beginning of the 20th century, the incidence of the disease started to decline due to better hygiene and sanitation. A further dramatic decrease followed the introduction of penicillin in the therapy of sore throat and scarlet fever. However, rheumatic fever is not history everywhere. There are still geographic areas, such as the one you see, where the incidence of the disease represents a significant medical problem. And even within developed countries, such as in Australia, there are still significant differences between ethnic groups due to inequality. The decrease of acute rheumatic fever was paralleled by a corresponding decrease of the chronic valvulopathy, that is rheumatic heart disease. Here you can see the case of Italy. Still the leading cause of heart failure up to the 60s, 70s, the incidence of the disease started to decline and it has almost vanished. A recrudescence has been observed in the last few years due to migration flows. The star indicated the year 1994. That was the year in which the Hector Massimo Troisi died because of a mitral valvulopathy. I guess it was one of the last to die of this rheumatic fever, because he had a history of rheumatic fever in his adolescence. And the decline of rheumatic heart disease occurs worldwide, but not at the same rate everywhere, still because of the differences between developed and less developed countries. Now, why the disease is called rheumatic fever? The name, as in other diseases, comes from the two main symptoms, that is fever and rheuma. Fever does not require any further clarification, I guess. Rheuma calls for some clarification. In its common meaning, rheuma means pain of the joints and muscle attributed to atmospheric influences, particularly cold and humidity. And rheumatism, therefore, was the disease characterized by the presence of rheuma. However, this was not the original meaning of the term rheuma, which comes from the Greek verb rheo, meaning to flow. Therefore, literally, rheuma means something which flows, a flux. And in fact, we can find rheuma defined in this way in one of the first printed medical books, that of the Spanish physician Luis Lobera de Avila, who defined rheuma as the flow of humors from the head to the other parts of the body because it is a humor in motion, a flux. In this slide, for your convenience, I have summarized the core concept about rheuma in ancient medical text. So rheuma was a flow that formed in the head from vapors rising from the site of digestion. In the head, these vapors condensed, becoming phlegma, one of the humors of the ancient Greek medicine. In the presence of an excess of cold and humidity, phlegma was formed in surplus and therefore was transformed into rheuma, which then flowed from the head to the various parts of the body. But what is most important is that rheuma was not simply a symptom, but it had a pathogenetic role, as you can see easily from this quotation, where reuma is defined the mother of diseases. This is a term which we learn from some other historical situation, that is the first Operation Desert Storm, as you can see, the mother of all the wars. And in fact, we can find reuma defined in this way, again, by Luis Lobera di Avila, in stronger terms, is the mother of diseases, a source of ruin, the origin and cause of many diseases, depending on the body parts towards which the reuma flows. And in fact, this concept that reuma had a pathogenetic role was still well rooted in 19th century medicine. Here you can see a long list of diseases having a rheumatic origin. This list was printed in 1811 by the Austrian physician Franz Suedior. And what is interesting is that beside severe diseases such as encephalitis, phrenitis, pneumonitis, even headache and toothache had a rheumatic origin. And obviously, when the reuma went to the joints, it produced all the types and forms of gout that existed, according to the words of Lobera di Avila. Here, the Spanish physician used the term gout as a catch-all term, comprehending all diseases characterized by pain in the joints. In time, the use of the term reuma in the medical literature fell out, mainly because the ancient humoral Greek theories were substituted by the modern cellular theories put forward by Schleiden, Schwann, and Virchow in the first half of the 19th century. So based on this historical analysis and based on current knowledge, we can therefore conclude that the use of the term rheumatic is essentially a linguistic fossil, a historical misnomer that has been retained for traditional reasons despite its etiological inaccuracy. And in fact, the other sequela of streptococcal infection, that is glomerulonephritis, is correctly named post-streptococcal glomerulonephritis. However, this is not the only case in medicine, because there are other diseases such as mycotic embolism and mycotic aneurysm, which are still named incorrectly because of the same traditional reason. Now, let's see how rheumatic fever was identified as a specific disease. This was a long journey, and here you can see the long list of the steps that were necessary to accomplish this task. Now, I will try to explain one by one, starting from the first descriptions of the disease. Traditionally, the English physician Thomas Sydenham is considered the one who gave the first description, which is this one in 1676, where you can see he described this disease characterized by de-inflammatory signs, systemic fever, and migratory pain, rubor, and tumor. In my opinion, however, a plausible description of the same disease was given a few years before by the French physician Guillaume de Bayeux in this book. As you can see, I have evidenced in red the signs of inflammation, again, pain, rubor, and calor, alongside with the presence of a fever. The next step was to distinguish between acute and chronic forms of rheumatism. And this was a collective effort that was worked out by several authors between the end of the 18th century and the beginning of the 19th century, so that by the first half of the 19th century, it was clear that rheumatism existed in two forms, one acute and one chronic. It is important to know that in 1805, the term acute articular rheumatism, that is rheumatismo articolare acuto, was introduced in the medical literature. This term is important because it was common use. It was a standard use instead of rheumatic fever up to the 20s of the 20th century, when it started to be officially replaced by the term rheumatic fever. But when I studied in the 70s, it was still in use. And the next step was to separate joint disease, this catch-all term, in specific pathological entities, that is gout, rheumatoid arthritis, and rheumatic fever. And this was mainly the merit, I believe, of the great Alfred Baring-Garrod, the man who linked gout to hyperuricemia. And this fundamental table was published in 1859. Here he used for the first time the term rheumatic arthritis, which was subsequently worked out by his son Archibald Garrod. And clearly you can distinguish gout because of the presence of high uric acid in the blood from acute rheumatism and rheumatoid arthritis, which are not. These two last diseases are differentiated because of the age, juvenile in the acute form, aged people in the chronic form, by the course, acute and chronic, and by the presence of fever, which was severe in the acute rheumatism and minimal or absent at all in the case of rheumatoid arthritis. The next step was the recognition that angina faucium, that is sore throat, the same applies to scarlet fever, was a necessary positive anamnestic data in the medical history of rheumatic fever patients. The first hint in this direction was given by the French physician Armand Trousseau, which is another most famous name in the history of medicine. He briefly mentioned an angine rheumatismale without giving any further clarification. Far more precise was Sir James Kingston Fowler, who in the 1880 was the first to establish as a rule the necessary association between sore throat or scarlet fever, in this case tonsillitis, and rheumatic fever. And his conclusions were further strengthened by the pediatrician Walter Butler Cheadle, who again reported the same association. So that by the end of the 19th century, it was pretty clear that an association existed between sore throat and scarlet fever and rheumatic fever. In time, the the bacterial origin of sore throat was worked out. This is a table from a paper dated 1935, listing the biological characteristic of the streptococci associated with the sore throat in rheumatic fever. They belong to group A. This is important. This is a question which I used to make to my students, and they always failed. So group A, beta hemolytic, is important to remind. They produce streptolysin, that are toxins, and these toxins in turn give rise to high titers of antibodies, which are important because they are diagnostic, so they have to be remembered. The next step, the fact that sore throat had a bacterial origin put forward the hypothesis that also cardiac lesion had the same bacterial origin. And after a few initial positive evidences in this case, in this direction, which were not further confirmed, it came out that bacteria could not be demonstrated in cardiac lesions. In other words, Koch criteria, which are necessary for establishing the bacterial origin of any disease, were not fulfilled in this case. And this in turn led to the suggestion that the lesion was probably due to a host response rather than being a direct bacterial damage. And in fact, this was worked out. Now we know that it is, in fact, a mechanism of molecular mimicry. This mechanism was clarified in the 60s by a bunch of papers mainly published by this author, Menry Kaplan, which is apparently unknown in the literature, who first demonstrated that antibodies to group A streptococci cross-react with heart tissue. The establishment of the diagnostic criteria is mainly the merit of the American physician Thomas Duckett Jones, who in 1944 published this fundamental paper in which he put forward what are known now as Jones criteria. He grouped this criteria in two groups, major and minor, major or minor, depending on if you want to use the English or the Latin. And the major are carditis, polyarthritis, chorea minor, subcutaneous nodules and erythema marginatum. The minor criteria are fever, arthralgia, elevated erythrocyte sedimentation rate, now known as VES, and neutrophilic leukocytosis. For the diagnosis of rheumatic fever, 2 major criteria are necessary, or 1 major plus 2 minor criteria. These criteria in time have been revised, but they still maintain their fundamental importance. And the same name Jones is also used as an acronym to remind these criteria. J stands for joint, O stands for heart because of the shape of the heart, N stands for nodules, E stands for erythema, and S stands for Sydenham, because Thomas Sydenham, again, was the first to describe chorea minor, which is obviously different from chorea major of Huntington. Clinical manifestations do not occur all at the same time. Here you can see that the first are polyarthritis, carditis, and erythema marginatum. Chorea and subcutaneous nodules follows. Let me show you these images, which are the first printed images of nodules and erythema marginatum by Cheadle on the left, and the microscopy of the subcutaneous nodules, again by Cheadle in 1889. So they are very historic. A fundamental step was the introduction of penicillin in the therapy of the sore throat and scarlet fever, because it resulted the best way to prevent rheumatic fever. The first paper was published in 1950, and it clearly demonstrated that the treatment by penicillin of preceding streptococcal infections resulted in the dramatic increase of the incidence of rheumatic fever. So that by 1952, it was possible to publish the conclusion that is the best way to prevent rheumatic fever was to treat the preceding streptococcal infection. Now, this year, 1952, is of some interest because in the same year started the commercialization of cortisone by the Merck. And the reciprocal use of these 2 drugs, penicillin and cortisone, is interesting because penicillin prevented the rheumatic fever but did nothing on rheumatoid arthritis, and still the possibility of a bacterial origin of rheumatoid arthritis was suggested at the time. I believe my friend Piero Masson, rheumatologist, can confirm this concept. Penicillin did nothing on rheumatoid arthritis, whereas cortisone was not useful for preventing rheumatic fever, but it was of the most importance in treating the potentially fatal myocarditis of rheumatic fever. And again, it was very important. It was the first effective treatment, symptomatic treatment for rheumatoid arthritis patients. And in fact, led to the Nobel Prize of 1950 to the rheumatologist Philip Hench of the Mayo Clinic for this reason. Let me show you this picture. It is a painting from the American painter Norman Rockwell. And you can see this kid that is waiting for his shots of penicillin. And images like this were used to advertise the major health campaign that were launched in the United States in the 50s for preventing rheumatic fever by penicillin treatment. I have left the last, the identification of the heart. It is the cardiac involvement, because it is a long and complex story. I shall summarize some points. That is, the concept was evolved in 19th century by a collective effort by pathologist Edward Jenner, for example, which is most famous for vaccination of smallpox, and the clinicians. The term was introduced in 1812 by Charles Wells, but I believe that the most famous name in this case is that of the French physician Jean-Baptiste Bouillot, who was one of the first to use the recently introduced stethoscope for auscultating the heart. And thanks to this examination, he quickly realized that the involvement of the heart in rheumatic fever was not the exception, but it was the rule. And in fact, he put forward in 1836 what is still known as the law of coincidence, establishing firmly this point. And in fact, we know that in rheumatic fever, there is a pancarditis, that is, all layers of the heart are involved. By the second half of the 19th century, it was pretty clear that the most common causes of pericarditis and endocarditis was in fact a rheumatic fever. And this is for my friend, Professor Tiene. This is another most famous French physician who put forward the most famous aphorism on rheumatic fever, which every student should know, that is, acute rheumatism licks the joints, but it bites the heart. And this is the first microscopy of a mitral valve involved in rheumatic fever. And you can see in the bottom part especially the presence of quite a bit of nuclei representing inflammatory cells. Let me finish with a few slides of the histopathology of rheumatic fever, myocarditis and rheumatic fever, because it is important, because it is potentially fatal. And because it is a diagnostic that is specific of the disease. The lesion currently goes by the name of Aschoff nodule because this lesion was first described by the German pathologist Ludwig Aschoff in 1904. He called these nodules noduli rheumatici. At that time, the Latin was still the French, the most used language in this case. No, the most famous fifth sign of inflammation, functio lesa, is called functio lesa, not because it was introduced by Galen, who obviously wrote in Greek, but because it was introduced by Rudolf Virchow, who used the Latin language. Aschoff did not publish any image of the nodules, which were in turn published by Paul Geipel, another German pathologist, 1 year later. And here are Geipel's image. On the left, you can see a low magnification transverse section of the heart stained with hematoxylin eosin. The red portion are the myocytes, whereas the dark areas are the nodules, which appear dark because there is plenty of inflammatory cells over there, and they stain with hematoxylin. On the right, you can see a higher magnification longitudinal section of a classical nodule with the central portion surrounded by lymphocyte mainly. And these are mine images of Aschoff nodules. You can see a classical, I would say, nodule. You can see the nodular localization, the small amount of cells, some of them peculiar, I will describe them later, and some of them lymphocytes, interrupting the continuity of myocytes. Often, these nodules are localized in close proximity of small vessels. And from this slide, and I guess even more from this, you can realize the extent of damage done to the heart, and you can understand why the myocarditis can be fatal, because there are two main functional consequences. First, impaired contraction, and second, impaired conduction. Therefore, there is the possibility of arrhythmias. As I said, beside inflammatory cells in the lesion, there are also cells known as Aschoff cells. And here are the Aschoff cells indicated by the arrow. They are cells greater than normal, sometimes giant, but they are not really giant. They have a variable size and a variable morphology, basophilic cytoplasm, and mostly the presence of many nuclei from 1 to 4 generally, but even more. And here you can see a greater magnification of a small group of Aschoff cells, and you can see here the differences in variability in size, the difference in morphology, the basophilic cytoplasm, and the variable amount of nuclei. In the same nodule, there is also another type of peculiar cell, which is called Anichkov cell, by the name of the Russian pathologist Nikolai Anichkov, a pupil of Ashov, who first described them in 1913. And here you can see the original drawing by Anichkov, but let me show you an enlargement, and you can see these typical cells characterized by elongated nuclei, having along the longitudinal axis the condensed chromatin. Now, this pattern is peculiar, and it is called the caterpillar pattern, bruco, because it reminds a caterpillar, a bruco. And here you can see quite a bit of Anichkov cells in caterpillar pattern indicated by the arrows in the case previously described. The caterpillar pattern, however, is not the only pattern of appearance of Anichkov cells. There is also another pattern which is called all eye, the one on the right. Now, these are one and the same cells, the difference depending on the section orientation. When in longitudinal section, the pattern of appearance is caterpillar. When in transverse section, the pattern of appearance is all eye. And let me finish with 3 slides demonstrating the evolution of the Ashov nodule. The first phase is the formation of a new exudate, which appears amorphous because there are no cells, and is stained with eosin because it is of protein origin. This phase is followed by the formation of an early Ashov nodule, which is characterized already by the nodular appearance and by the presence of Ashov cells, but lymphocytes are lacking. And finally, the advanced Ashov, where there is quite a bit of lymphocytes. This lesion can heal by substitution with connective tissue, and therefore the final evolution can be a myocardial scar like this. This is anyway a dangerous evolution because this scar can act as an arrhythmogenic focus and can be at the origin of dangerous arrhythmia. So I'm done for today. Thank you for your attention.